In this lecture, we'll be going over all of the non-Alzheimer's related dementia syndromes. And fortunately, these are all have unique features. So it's sort of like the Parkinson's lecture. Conditions like multisystem atrophy or PSP can superficially look like Parkinson's, but if you're aware of the distinct differences, then usually you'll think of an alternative diagnosis. So it's rather similar with Alzheimer's. Now, one of your classmates, I thought, sent a very good question about management. And I know there are some UWorld AMBOSS questions. Someone sent me a question, AMBOSS question about a very new multiple sclerosis medication. And someone else sent a question about treatment of Wilson's disease. And I used to go into that a bit more, but it appears to me that these are now more relegated to step 2 clerkship examination questions. So for example, for step 1, after August 2020, notice there were 7 to 12% of questions were management questions, and now the National Board has stated that 0% are management. And so I've wondered, I mean, pharmacology is all about management, but I think just kind of the nitty-gritty of how do we treat some of these conditions, especially the less common conditions, I don't think those are being included on step 1. So that's why we're steering more towards making the right diagnosis, understanding the pathophysiology, and so on. So our next dementia syndrome is multi-infarct dementia. And this is either the second or third most common dementia syndrome. And in contrast to Alzheimer's, where there is just a steady decline in memory function, in multi-infarct dementia, with each stroke, patients take a sudden drop in their cognitive function. And we'll discuss in the stroke lecture, but when someone has a stroke, they're at their worst at the beginning, and then they improve. And that's often how the memory loss is in multi-infarct dementia as well. So over time and rehab, their language and some cognitive function can improve, but then when they have another stroke, usually they get hit even harder, because just kind of like multiple sclerosis, the more of the brain that's involved, the more difficult it is to recover. So these are frequently cortical strokes, and by that I mean middle cerebral artery, anterior cerebral artery, posterior cerebral artery. These are really bad when you have them. And if you have more than one cortical stroke, then there is going to be some component of multi-infarct dementia. So each stroke progressively gets worse. And so anytime we have someone who has cognitive complaints, of course you're going to ask about a history of stroke, but these patients will also have focal deficits. Right? So there's going to be some residual hemiplegia, some aphasia that's out of proportion to the other difficulties, visual field deficit, and so on. Now, what occurs all the time is that we have a patient that has both Alzheimer's and multi-infarct dementia. Because remember, the risk factors for both conditions are all of your vasculopathic risk factors: hypertension, diabetes, dyslipidemia, smoking. These are all risk factors for Alzheimer's, and of course these are all risk factors for stroke as well. And so how that presents then is someone has a stepwise decline, but then they're also having just a steady progression on top of that, where every few months seems to get worse. Now, perhaps less common, although I made a bigger deal of this in years past, but subcortical strokes, these are not good either. So the cortical strokes are more likely to contribute to cognitive changes, but I think more and more it's being appreciated that just the more even subcortical ischemia you have, that can also lead to multi-infarct dementia. And the subcortical strokes in particular, and I mentioned this in the lecture on subcortical central nervous system anatomy, there you're knocking out the cortical bulbar tract. And so these patients have pseudobulbar palsy, okay, and this is what we call a subcortical dementia. which looks a lot different than Alzheimer's. You know, the Alzheimer's patients comes in, they're telling you jokes, they're gregarious. Lots of subcortical strokes lead to more of a withdrawn, depressed appearing patient. Apathy is commonly seen in those patients. Okay, so here we have lots of subcortical strokes. Okay, and here we have a patient that has a left PCA stroke, a bilateral ACA stroke, a left MCA stroke. You know, so this patient is certainly going to have multi-infarct dementia, and with this much damage to the brain subcortically, you'd expect this to be your kind of withdrawn, depressed appearing patient with pseudobulbar palsy. So that combination, because you know a vasculopath patient is at risk for Alzheimer's and stroke, leads to a very common diagnosis we make known as a mixed dementia. Okay, and so they have a combination of a stepwise decline and they have a gradual decline. So here we have Alzheimer's, which is the most common. Okay, but here we have vascular brain injury. So these intersect, and then the second or third most common cause of dementia, dementia with Lewy bodies, we'll talk about in just a minute, this often will intersect as well. And so this is why frequently we can't be incredibly confident about the etiology of the dementia. But if you're having, you know, the patient has had strokes, they have a stepwise decline, but then they just seem to be gradually getting worse, you're probably dealing with a mixed dementia syndrome. So now we've listed all the things that cause pseudobulbar palsy. Well, not all the conditions, but the ones that you need to know. So remember, the common thing they all have, you know, in common is involvement of the corticobulbar tract. So in multiple sclerosis, it's demyelination of the corticobulbar tract. In ALS, the cortical neurons degenerate up in the precentral gyrus. In PSP and MSA, you have more of a midbrain issue that involves the corticobulbar tract. And then in this lecture, multi-infarct dementia, you have lots of subcortical strokes. Okay, so again, that emotional incontinence, easy laughing, easy crying, kind of a patient. Okay, so the third, now if we include mixed dementia, that's probably the second most common cause of dementia. But right up there is a condition called dementia with Lewy bodies. And this is what Robin Wilson had. And so think of dementia with Lewy bodies as a condition that sort of overlaps between Alzheimer's and Parkinson's. Okay, so this is a relatively new condition, mid-1990s, and basically they found in these patients that there were Lewy bodies, not just in the substantia nigra like you see in Parkinson's disease, but diffusely throughout the brain. So the older term was diffuse Lewy body disease. Now it's just dementia with Lewy bodies. So again, it may be the second most common cause next to Alzheimer's. So frequently we're trying to determine, since these patients are Parkinsonian, are we dealing with Parkinson's disease with dementia or dementia with Lewy bodies? Okay, and the rule of thumb is if the dementia begins 1 year after the onset of Parkinson's symptoms, then we call it just Parkinson's disease with dementia. Okay, if the cognitive symptoms begin within the first year of some Parkinsonian features, then we're going to call that dementia with Lewy bodies. So here are the 4 cardinal features of dementia with Lewy bodies. The one that probably should jump out at you the most is these patients have profound hallucinations early on in their course. That's often, you know, the initial, most dramatic symptom. You know, they're calling the police because someone threatening is at the door. They're seeing people in the backyard. You know, I have a patient that he started seeing these fish with teeth that would come out of the bed and were very threatening. So these are often very dramatic, scary hallucinations. And so these patients do have motor features of Parkinsonism, and so you might be confused because we talked about hallucinations in patients with Parkinson's disease, but that is only when you give someone dopamine medications. Okay, you give them a dopamine agonist, you give them carbidopa, levodopa. Hallucinations are an organic part of the condition in dementia with Lewy bodies. So it's not caused by a medication. Okay, so that's the major difference there. Another classic feature of dementia with Lewy bodies is these patients have significant fluctuations. I just saw a patient this week, and he was having some hallucinations, and his spouse said, some days he is just great, goes out, he mows the lawn, and he's interactive, and some days he just won't get off the couch, and he seems almost non-responsive. So these significant fluctuations, often in cognition, are a classic feature of dementia with Lewy bodies. Remember that REM sleep behavior disorder is seen in the synucleinopathies. So remember from the Parkinson's lecture, that's Parkinson's disease, seen in up to 60%, multisystem atrophy. And this is our third synucleinopathy, dementia with Lewy bodies. And in this condition, it's even more commonly associated. More than 90% of patients with REM sleep behavior disorder will eventually develop dementia with Lewy bodies. So even more common than Parkinson's. The tremors are not as dramatic as we see in Parkinson's disease. These patients, sort of like multisystem atrophy, are especially prone to orthostasis, so that's something to be aware of. And these patients are hypersensitive to neuroleptic, antiemetic, dopamine blocking medications. Even a single dose of a dopamine blocking medication can be a huge setback for these patients. I had a patient with this who went to Hawaii. He got sick, was nauseated, went to the emergency room and was prescribed metoclopramide, a dopamine blocker, and it took him more than a month to recover from taking one dose of that. So just remember, dopamine blocking medications are not good in Parkinson's patients, but they're very problematic in patients with dementia with Lewy bodies. And 10% of patients can have what's called Capgras syndrome, which is kind of an interesting phenomenon. Typically the spouse, or they believe that their spouse, it looks like their spouse, but it really isn't. It's someone who is an imposter. And this can be a fixed belief that is, very distressing for the family. So in terms of pathology, I know Dr. Deich will go over this, so I'll be brief, but you find Lewy bodies not just in the substantia nigra, but they're found diffusely throughout the brain. So they otherwise just look like Lewy bodies. So you affect dopamine-producing neurons in the substantia nigra. That's why they look Parkinsonian. Okay, but you also involve the acetylcholine-producing areas of the brain, like the nucleus of Maynard. So that's a pathophysiology of Alzheimer's. Okay, so they have overlapping Parkinson's, Alzheimer's features. Okay, and they have atrophy, just like someone with Alzheimer's has atrophy. And maybe a contrast, they're less likely to have the neurofibrillary tangles as compared to an Alzheimer's patient. So again, you need to be able to recognize what a Lewy body looks like. So in terms of treatment, very difficult. So let's say someone is Parkinsonian with this, so you want to give a little of a dopamine agonist, or you want to give the patient levodopa. Well, they're already hallucinating. So now you want to give them a dopamine medication, and so treating the Parkinson's is extremely difficult because you tend to significantly worsen the hallucinations. So maybe you want to treat the hallucinations with a neuroleptic. Well, remember, they're super sensitive to dopamine blocking medications. So that becomes very tricky as well. So again, we'll use atypical neuroleptics. So I'm repeating this again, but quetiapine would be a good choice for these patients because it has relatively little effect on dopamine. And of the acetylcholinesterase inhibitors, I talked about donepezil with Alzheimer's, and rivastigmine has the most evidence for dementia with Lewy bodies. And I always wondered why that was, because the same class of medications, and it just came out a few months ago actually that rivastigmine has an effect on the orthostasis. So it also improves the orthostasis, and that may be why patients did better in clinical trials on the rivastigmine. You don't need to know that, but it's just something I learned recently that I thought was kind of interesting. Okay, so just Parkinson's disease. This is just because Parkinson's is so common and they develop dementia late, that makes Parkinson's disease a relatively common cause of dementia. So somewhere between 30 to 40%. Remember, in Parkinson's disease dementia, the dementia occurs greater than a year after the onset of symptoms, and in my experience, it's much later. So it's not certainly not within a year. It tends to occur many years down the road. Okay, so overall risk of dementia in patients with Parkinson's is about 4 times higher than in age-matched individuals, and that makes the Parkinson's very difficult to treat, because you've got dementia and you give a medication that causes hallucinations, and that merges into a delusion. So management is often very tricky for these patients. Okay, so again, I'll just remind you here of our 3 most common causes of dementia, and that certainly there's a high overlap between Alzheimer's and vascular stroke, multi-infarct dementia, but also with dementia with Lewy bodies. Okay, and so in autopsy studies of patients with dementia, we're often finding a combination of Alzheimer's findings, vascular findings, and then we occasionally find Lewy bodies throughout the brain as well. Now, frontotemporal dementia is another relatively common cause of dementia. One clue here is that the age of onset is younger. Mean age of onset is 58. Remember that Alzheimer's is very uncommon under the age of 60. So if we have a younger patient, that would put frontotemporal dementia higher up. And so the degeneration occurs mainly, as the name indicates, in the frontal and temporal lobes. Now, this is not the primary motor and sensory cortex, so more the association cortex of the frontal and temporal lobes. Okay, so it overlaps with Alzheimer's, but one big difference, I would say, Alzheimer's presents typically with the amnestic variant. They're having anterograde amnesia, episodic memory loss. In frontotemporal dementia, the presentation is usually more of a behavioral personality change. Okay, so that should be a clue, a younger patient with behavioral issues. Okay, and if the degeneration occurs more on the language-dominant hemisphere, and oftentimes this will occur back in the temporal lobe, then you'll have a patient that has a progressive receptive aphasia. They look kind of like a Wernicke's patient. They're fluent, but they're not understanding what's going on. So that's a common variation of frontotemporal dementia. So the most common features of frontotemporal dementia, because of the area of the frontal lobe that's involved, these patients are disinhibited. I think I gave you the example of the patient I saw recently that was very loud, argumentative, political discussion with another veteran in the waiting room, and then made an inappropriate comment about the medical student, and then was just really irritable in the office and said things that his wife was embarrassed about and said, he's never like this. So they lose the filter and they just say what's on their mind. Also, from involvement of the frontal poles, remember that most anterior part of the frontal lobe, these patients have a loss of empathy. So you want family members there who can tell you, they'll just say, he's just not the same. And again, I think I gave the example of the spouse recently got breast cancer and he seemed rather uncaring, which was not like how he'd been. Hyperorality is a classic feature of frontotemporal dementia. And so usually this is a fixation on sweets, and so they'll have weight gain along with this. And then some compulsive behaviors. So I've had patients that just fixate on a stamp or a coin collection. They were kind of into that before, but now it's all they want to do. Or I had another patient that only wanted to go to the beach with his metal detector to look for things, and it just became that's all he wanted to talk about. So those kind of compulsive behaviors are common. So the behavioral variant of frontotemporal dementia describes these 4 features here, and that makes up at least 50%. Remember the progressive aphasia as another presentation, a dominant hemisphere presentation of frontotemporal dementia. Now, in our lecture on ALS, I mentioned a genetic lesion there, the C9orf lesions that are associated with ALS, but also overlap with frontotemporal dementia. So up to 20% of patients with frontotemporal dementia can develop a motor neuron disease. So this is just the slide that I showed you here. So just to remind you, it's the C9orf72 mutations, okay, that are responsible for almost half of familial ALS, and we've got that overlap here with frontotemporal dementia. Okay, so if we just look at the brain here, if you're shown this, notice just the focal frontal atrophy. So the key thing is the focal atrophy, in this case frontal lobe, but we could have certainly involvement of the temporal lobe, but here is just showing you the selective atrophy of the frontal lobe. So in Alzheimer's, again, just the whole brain is atrophic. Okay, and I'll let Dr. Deich go over the neuropathology, but again, overlaps with Alzheimer's. And these patients, since they have such significant frontal lobe involvement, will almost certainly exhibit some of those frontal lobe release signs, the glabellar, palmomental, grasp reflex, and so on. All right, so synucleinopathies, again, are Parkinson's, multisystem atrophy, and dementia with Lewy bodies. Remember, all of these then are associated with REM sleep behavior disorder. Tauopathies are PSP, Alzheimer's, and frontotemporal dementia. So this is just a little table here that I made to illustrate kind of the differences. So onset, a younger patient, frontotemporal dementia. Okay, in Alzheimer's, it's going to be early on memory. In frontotemporal dementia, more personality. Okay, in dementia with Lewy bodies, remember significant fluctuations with hallucinations and REM sleep behavior disorder. In multi-infarct dementia, you've got stroke, focal findings. In Alzheimer's, it's just a steady downhill. Same thing with frontotemporal dementia. Remember, in the dementia with Lewy bodies, you've got the day-to-day significant fluctuations, and a multi-infarct dementia, a stepwise decline. Okay, in terms of motor symptoms, patients with Alzheimer's have significant apraxia. Patients with frontotemporal dementia are most likely to exhibit those frontal lobe release signs. Patients with dementia with Lewy bodies have Parkinsonism. Patients with multi-infarct dementia are likely to have a hemiplegia, some focal weakness. So if we image in Alzheimer's, we'll look for that hippocampal atrophy on an MRI, whereas in frontotemporal, it's going to be selective frontal and temporal atrophy. Dementia with Lewy bodies, it's generalized atrophy, and then we're going to find strokes in multi-infarct dementia. Okay, and then the pathology here, Dr. Deich has gone over with you. So just remember that mixed dementia, where we get a combination of all of these, is super common. Now, Huntington's disease is a condition that has a nice triad here. It usually presents with some behavioral issues that then merges into dementia. So in that sense, it overlaps with frontotemporal dementia. So patients I've seen with this, get into an argument with their boss, lose their job because they're arguing with customers, or it can be anxiety, depression, delusions, and then that kind of merges into memory loss. Okay, they have the choreiform movements, which is classic. Remember, chorea in Greek means dance, and you look for a family history. So we've been over this in the movement disorders lecture, but since we're now talking about dementia, I just wanted to remind you again. And remember, early on they have excessive movements, and then they merge more into a Parkinsonian dystonia type movement. And you're going to look for that focal atrophy of the caudate nucleus. And remember, this is our third trinucleotide repeat condition we've mentioned in the course. And I've showed this several times here. Yes, we've got generalized atrophy, but there's no caudate. Now later on we talk about HIV, and so I just have one slide on this just to say that patients who are HIV positive as a late manifestation of AIDS have this HIV-associated dementia syndrome. It tends to be a subcortical dementia, meaning kind of a withdrawn, apathetic, depressed appearing patient. And probably just the most important thing for me to say in terms of a summary point is anytime we have someone HIV positive who's having progressive cognitive decline, we do a complete workup because you don't want to miss something that's treatable, some infection, so this is a diagnosis of exclusion, so we're going to do an MRI scan, we're almost certainly going to do a lumbar puncture, big workup to make sure there's nothing fixable, because once we've diagnosed this, the prognosis is poor. Now, Jakob-Creutzfeldt disease, and you will see it often called CJD, Creutzfeldt-Jakob disease. Most neurologists kind of compulsively like to call it Jakob disease, Jakob-Creutzfeldt disease. I put this in the footnote, but it's just an interesting story. Both Dr. Jakob and Dr. Creutzfeldt in the 1920s were describing these patients who had kind of a rapidly progressive dementia. And so for a while, the name of the syndrome was named after those two doctors. Well, it turns out a long time later, you could go back and look at the brains of Dr. Jakob's and Dr. Creutzfeldt's patients, and only Dr. Jakob's patients had the Prion's disease, so it was called Jakob's disease. And then as I understand the story, a researcher at NIH whose initials just happened to be CJD, knew the story here, but I think thought, well, it would be cool if this condition had my initials, and so he started calling it Creutzfeldt-Jakob disease, so that caught on for a while, and then only more recently did people discover sort of how that evolved. So anyway, that's not important. But Jakob-Creutzfeldt disease is not common. It's like a 1 in a million diagnosis, although I think I've seen at least 3 cases just in the last 2 years. But this has a kind of a younger, around 60 would be kind of a typical age of onset. And so this condition, unlike the others, has a rapid progression, much more rapidly progressive than all of the other dementia syndromes. I mean, week by week, these patients are declining. So this is the most common cause of a rapidly progressive dementia. So we have a triad also for Jakob-Creutzfeldt disease. They have these myoclonic jerks. And we'll talk about myoclonus in the epilepsy lecture. These are not epileptic. So myoclonus can be epileptic or non-epileptic. We've all had myoclonus. When you're falling asleep and you're alerted and your whole body jerks, that's myoclonus. Okay, that's normal myoclonus. But here, these patients have quite profound myoclonic jerks that are stimulus-induced. So when we go into the room, maybe we just make a little noise going into the room, we'll see the patient's whole body jerk. If you make a loud noise, you'll see a myoclonic jerk. So that's kind of a unique feature. And then cerebellar pathways tend to be involved in Jakob-Creutzfeldt disease. So ataxia is quite a common feature. So that's our triad for Jakob-Creutzfeldt. Most patients die within 6 months. So that's what I mean by, rapidly progressive. Remember, Alzheimer's patients can live for, well over 10 years. So Jakob-Creutzfeldt is a prion disease, which means a proteinaceous infectious particle. So the infectious agent is only protein. And Dr. Deich has shown you that this causes the brain to have a spongy appearance, these big holes of empty space. So you lose brain, neurons, and you get astrocytic proliferation. So the prion that causes, and here I can't I want to call it Jakob disease, but here I put CAJD, has two forms. So there's a native form that is present in healthy cells. And it's felt that this has something to do with normal signaling between neurons. Okay, but the abnormal form leads to this kind of rapidly progressive refolding of all of the other prion proteins into the abnormal form. Okay, so a medical student made this drawing for me here to show you, here are the normal prion proteins. Here's a normal prion protein here. Okay, and what can happen is when it folds into the abnormal form, then that leads the next prion protein to fold into the abnormal form. And that then talks to another prion protein which folds into the abnormal form. And then this moves from one neuron to the other, and so you get this kind of an exponential process of abnormal folding of prion proteins. And you get neuronal death, and then it spreads on to other neurons. So what appears to happen is here you have the normal prion protein and the abnormal prion protein, which is prion protein scrapie, which is named after a prion disease that affects sheep. And it's felt that in the combination between the normal and the abnormal form, there's some intermediate form that is yet not been identified yet, but it's called protein X. Okay, and then that leads now to two abnormal prion proteins. So we go from one abnormal prion protein to 2 to 4 to 8 and so on. So again, it's that kind of an exponential misfolding of these prions. That's why it's so rapidly progressive. So this condition, and I really wish we had time, we talk about this in the second year course, about a condition called autoimmune encephalitis, which can have overlapping features. So there is a differential for a rapidly progressive dementia. But when we think about this, we want to do 3 tests here that can be very helpful. First of all, we do an EEG. This is our topic for next week. So we see these bursts. An EEG measures brain electrical activity. Kind of think of it as the equivalent of an EKG, electrocardiogram for the heart. And so when we do check the brain waves here, we see these periodic sharp wave complexes that can be quite pathognomonic for Jakob disease. We do a lumbar puncture. Now, we used to always check the 14-3-3 protein, which we do, but now there is a much better test called an RT quick test. Okay, and this test, when you do this, you are converting the abnormal prion protein, it gets converted into amyloid. And so when you find that conversion, this is highly sensitive and specific. This is really a great test for Jakob-Creutzfeldt disease. Of course, we always do an MRI scan. And interestingly, look at the signal changes here in the caudate that lights up and the putamen lights up. Okay, and so this is the basal ganglia, and so that has something to do with why these patients have a movement disorder. They have myoclonic jerks. Okay, and the other classic finding in Jakob-Creutzfeldt disease is called cortical ribboning. Okay, the cortex of the brain just lights up. Okay, so this just reflects that rapid misfolding of prion proteins that happens in the cerebral cortex. So every case of Creutzfeldt-Jakob disease, Jakob-Creutzfeldt disease that I've seen is the sporadic form. That's certainly the most common. I did see one patient who had familial Jakob-Creutzfeldt disease. So this tends to be autosomal dominant, and there's a mutation of the prion gene. Okay, and so this is certainly genetics counseling. It would be very important so that individuals that have a family of history of this are aware of the ramifications of having children. Now the iatrogenic form is now much less common, but this has been associated with receiving growth hormone or dural grafts. There have been cases related to corneal transplant or receiving intravenous immunoglobulins. So obviously that's really bad. That shouldn't happen, but there have been cases of that. Okay, and then what people worry about is the variant Jakob-Creutzfeldt disease, the mad cow disease, where this could potentially go from cows to humans. This tends to have kind of a unique presentation in younger people that presents differently. I mean, it's still a rapidly progressive condition, but there are some distinct differences. But I think this is such an uncommon variant that I decided not to go into it. And at least as of the last time I looked into this, all of these cases were in England and France. I think there were a couple of cases in the United States, but these are individuals that came over from England and France. And there was this, I don't know, terrifying, is that the word to describe it here? Study of the British population that 1 in 2,000 individuals have the abnormal prion protein in their lymphatic system. So what does that mean about their later risk of, developing variant Jakob-Creutzfeldt disease? No one knows. But I would just say that another form of prion disease is called Kuru, which was mainly seen in New Guinea. There was a ritual that when a loved person would pass away, that family members would eat the brain to sort of internalize, the soul or the spirit of that individual. And they developed a prion disease that looked very much like the Jakob-Creutzfeldt disease. But interestingly, they developed this decades later. So there appears to be a really long incubation period for this. And so again, no one really knows what this means here, that there are so many of these abnormal prions in the lymphatic system in this study of a British population. So I show this just because it is interesting. I will not ask you, but in the variant form of Jakob-Creutzfeldt disease, you see this area of the thalamus light up right here. This is the pulvinar of the thalamus. And this is known as the hockey stick sign, because it kind of looks like a hockey stick. And so this would be kind of classic for this variant. Now, I just want to remind you of Korsakoff syndrome. We've already talked about it, but it's just such high yield. So remember, this is thiamine deficiency, where the patient comes in, they get IV glucose, they develop Wernicke's encephalopathy, and then if that is untreated, they can merge into the Korsakoff's syndrome. So remember, the triad for Wernicke's is the ophthalmoplegia, which is usually quite profound. They're confused, and they have a truncal gait ataxia. You give them thiamine, hopefully you make the diagnosis quickly. The ophthalmoplegia resolves pretty quickly, and then these problems will eventually improve with supplementation. Okay, so again, there are UWorld AMBOSS questions out there of alcoholics coming into the hospital or into clinic with Wernicke's, which is, I think, misleading. Most cases are patients who have a borderline low thiamine deficiency, and then they come into the hospital. It's iatrogenic, and they're given IV glucose. So don't give IV glucose, in the emergency room setting without also giving thiamine. You don't want to precipitate a Wernicke's encephalopathy. Okay, so Korsakoff syndrome, remember, is unique because most memory loss is anterograde, so the memory problems start with the onset of the disease. But in Korsakoff's, you have these pockets of memory that are lost from prior to the onset, and so this can go back for decades. So patients fill in the gaps, remember, and they confabulate. False invented memories. Okay, so you walk in and see these patients, they appear alert, they're engaging, but the more you talk with them, the more you see that they're saying things to sort of filling these gaps. They're quite fascinating people to talk to. So remember, here are the mammillary bodies. Remember, that's part of Pape's circuit. And so here we can see the mammillary bodies. So here's the midbrain, and so it's ventral to the midbrain. Here's the midbrain, and so here are the mammillary bodies right here. Okay, normal pressure hydrocephalus is unfortunately a very common board question. And the reason I say unfortunately is I really want to get the word out that this is a greatly overdiagnosed condition, but by the frequency of how often it shows up on national boards, you'd think that this is just right up there with Alzheimer's. Okay, so this is very uncommon. It has a triad. Okay, so if you see the triad, get the question right, but I want you to remember in your mind, oh, that's right, Dr. Cole said this is really uncommon. So you should not be diagnosing this. I mean, a neurologist in a 20-year career might diagnose one patient with normal pressure hydrocephalus. Okay, so the triad is a gait apraxia. That tends to be the earliest symptom. So again, what does an apraxia mean? It's the motor program for walking. So if you examine these patients sitting, in a chair, they've got normal strength, normal reflexes, normal sensation, but when they get up to walk, it often looks like, we call it a magnetic gait. The feet kind of seem glued to the floor, and taking that initial step is often very difficult, so it's a problem with gait initiation. Then once they start walking, oftentimes they can improve just a little bit. So that's the first symptom. Okay, then they develop dementia and urinary incontinence. This is the triad. So what's the problem with this diagnosis? Well, you could not come up with a more non-specific list of 3 problems. One of the most common things that I see every week are older patients referred for gait problems, which is frequently multifactorial. They've got some peripheral neuropathy, they've got hip or knee issues, they've got cataracts, so they can't see the floor very well. So gait difficulties are very common. Dementia is very common with age. And urinary incontinence, just think of all the men that have benign prostatic hypertrophy. So it's a super non-specific triad that many older patients have. So that's one issue. Over time, they can also develop some Parkinsonian features. So what's felt to happen in normal pressure hydrocephalus is you have an enlargement of the lateral ventricles, which we see here. So remember, you have the motor and sensory for the leg and for the bowel and bladder come here from the paracentral lobule, and on their way down they have to loop around the corpus callosum, okay, and then move down here to the spinal cord. So it's felt that you have an initial enlargement of the lateral ventricles, and maybe initially there was some increased pressure that was causing that, but the pressure eventually is normal, but yet because of the enlarged ventricles, and there's a math formula for this, but it affects tension here of the fibers from the paracentral lobule that are looping around the lateral ventricle. So you affect kind of the motor program up here. That's why you get the apraxia to the legs. Okay, but you also involve the frontal lobe, so you get a little dementia, and the paracentral lobule also has the important fibers coming down here for control of the bladder. Okay, so that's why you get the triad in normal pressure hydrocephalus. So what's the mechanism? Well, it may be that initially you get a failure of the arachnoid granulations to reabsorb CSF. That leads to a communicating hydrocephalus. The ventricle is large and they push forward against those midline pathways from the paracentral lobule. So why is NPH so often overdiagnosed? Well, one is the very nonspecific triad. The other is, if you do a brain scan in people as they get older, the ventricles look big. And if you go into radiology, please try to refrain from adding to your dictation of a patient that has what looks like hydrocephalus ex vacuo a comment like, can't exclude normal pressure hydrocephalus. Because I would say most of the referrals we get for normal pressure hydrocephalus are because that's listed in a radiology report. And so that's another issue. So in true normal pressure hydrocephalus, you get an enlargement of the ventricles, but very little cortical atrophy. So this would be a typical CT scan that you would get in an older individual. The ventricles are big, but look at how big the Sylvian fissures are and the sulci out here. So we have generalized atrophy, and so you're always going to have an enlargement of the ventricle. This is hydrocephalus ex vacuo. This is not normal pressure hydrocephalus, and we should not even consider that diagnosis when we have a CT that looks like this. So just to kind of support this, there was a study not too long ago of 563 cases of dementia. So this is a pretty good sample size. These patients were all evaluated by neurologists who were specialists in dementia. So of those 563 cases, these neurology experts actually felt that 9 of those patients had normal pressure hydrocephalus. But at autopsy, of those 9 cases, 8 had Alzheimer's disease, and the other had progressive supranuclear palsy. Okay, so in this study of 563 cases, it doesn't look like there was even one that really had normal pressure hydrocephalus. So the working theory is that most patients who look sort of like they might have normal pressure hydrocephalus, much more likely they have the onset of a neurodegenerative condition like Alzheimer's, progressive supranuclear palsy, or some other neurodegenerative condition. So NPH does exist. I don't want to make that point, but just be very, very careful. So one of the tests we do, if we think someone might have normal pressure hydrocephalus, is we remove spinal fluid, we do a lumbar puncture, do a high volume removal of spinal fluid to see if the patient walks better. Now we need to be very aware that patients have a placebo response when you do something like that, but that would be one of the tests that we would occasionally do. And so if we really think someone has normal pressure hydrocephalus, we can ask neurosurgery to put a shunt in, but the risk of shunt infection is not small, and so this is not just a benign thing to do this. Yeah, so the CSF tap test, but just be aware of the placebo effect. And finally, just even in true normal pressure hydrocephalus, there's a shunt risk, infection risk, but there's no evidence that shunting helps for more than 2 years. So it's not even just a slam dunk, even if we think someone really has normal pressure hydrocephalus, that they definitely should be shunted. It's a difficult decision. Yeah, in some studies up to 40% risk of shunt infection. All right, finally, just a few other conditions we should have in our differential. So I mentioned that just normal aging, you do have some age-related cognitive decline. And if we just look at this, kind of discouraging actually, but from our 20s on, there is a deterioration of speed of processing, working memory, long-term memory. So you guys are at your peak right now. It does tend to decline gradually with age, but notice what doesn't. Here, world knowledge, let's call this semantic knowledge. So this actually does improve with age. So again, our knowledge of facts and things like that can remain really steady or improve, but working memory, long-term memory, quick speed of processing, these things do go downhill over time. Remember, word finding difficulty is a universal complaint as people get older, so we don't want to overreact to that. I mean, take it seriously, but just recognize that that's really common. So we'll want to follow that patient, and if it doesn't really evolve much over time, then we'll just call it an age-related cognitive decline. It's not progressive. Now, patients who are depressed very commonly have complaints of memory loss, and we call that a pseudodementia. And so here are some things that just, when you're evaluating these patients, should suggest, okay, this is not neurodegenerative, it's more likely depression related. So the neurodegenerative conditions, by and large, begin in older individuals. Frontotemporal dementia can begin a bit earlier, but if you have someone in their 30s or 40s and they're concerned they're coming down with Alzheimer's, well, unless there's a strong family history, that's not what's going on. So variable age of onset, including younger individuals, we would see with the depression-related cognitive complaints. Onset, of course, in a dementia-related cognitive issue is often abrupt and with dramatic fluctuation. So I saw a patient years ago, and her memory problem began at her husband's funeral. Okay, the onset of Alzheimer's, no one can really pinpoint exactly when it happened. Yeah, it was last spring when we noticed some changes, that kind of a story. Okay, so a very abrupt onset, and patients will say, they have some days where they're great, thinking really well, other days they just can't remember anything. So again, that is not what we hear in patients with Alzheimer's. When we're doing cognitive testing in someone with depression-related memory complaints, oftentimes there's poor effort. And patients with Alzheimer's, they want to emphasize the positive things. They deflect. They don't want you to know that they don't know the date and so on. But a patient with depression-related memory problems, if they miss one point on cognitive testing, they may begin crying and say, you see what's going on with me, that kind of a thing. So they would emphasize their failures. Obviously, if we have a sad, teary patient with some personality changes, that would point to more of a depression-related issue. And this one here is really significant. So I mentioned that insight is affected in all of the neurocognitive issues. And so when I see someone in their mid-70s and the family is bringing them in for memory loss and the patient is saying there's no issue, I'm very concerned. The patient has no insight, the family is concerned. That sounds like Alzheimer's or some other neurodegenerative. If instead the patient is coming in, and I like to ask, well, what does your family think about this? And well, they haven't noticed that much. But if the patient is very concerned, and they have a high insight, they're very aware and distressed, so that high insight into any cognitive issues would suggest more of a pseudo-dementia. Okay, and when we do formal cognitive testing, and this can take hours with a neuropsychologist where they go over the same areas at various times throughout the test. In Alzheimer's dementia, the memory patterns are quite consistent. Okay? But in a pseudo-dementia, it's often very inconsistent, spotty deficits. Okay? And so in a pseudo-dementia, we see depression that is out of proportion, incongruent with the degree of memory loss. And so just making the diagnosis is important here, because if we're diagnosing a pseudo-dementia, then the treatment is really going to be cognitive behavioral therapy, potentially antidepressants, counseling, that kind of thing.